السلام عليكم ورحمة الله وبركاته. سعيدة إن أنا أكون موجودة معاكم النهاردة في مؤتمر المناعة والروماتيزم طب المنصورة. باشكر كل أساتذتي في الجامعة إن هم ادوني الفرصة دي إن أنا أقول كيس برزنتيشن النهاردة. حالة female patient 26 years old from شبين الكوم, housewife, married with one baby of 5 months with no special habit of medical importance. It was a consultation from Liver Institute of a patient with multiple complaints and delirium 1 week ago. Her present history started 5 months ago after delivery of her baby with tremors of both hands of gradual onset, progressive course. Tremors appear at rest, disappear during the line train movement of the affected arm, and with deep sleep. It was not associated with any other symptoms. No medical advice was done at this time, but the condition became more worse. 2 months later, visual and auditory hallucinations start to appear. Neurological consultation was done, and the doctor prescribed some medication, but without any improvement. 1 month later, the condition became more worse, with appearance of thumb rigidity of her body. They alleged that the convulsion sometimes occurred to her. So a neuropsychiatric consultation was done for her. Some medication were prescribed, and doctor asked them for EEG and MRI brain. And the EEG revealed no definitive abnormalities. While waiting for the MRI brain, 1 week later with this medication, the patient developed jaundice of gradual onset progressive course. No other important symptom at this time apart from her neurological symptoms were present. So she was referred for Liver Institute for evaluation of a patient with jaundice, and neurological consultation at this time revealed that the patient have a Parkinson-like, and MRI brain appear, and the investigation at this time revealed increase in AST, ALT, increase in bilirubin, virology were negative. Her CBC at this time, there was no abnormalities. And so what do you think? A patient with extrapyramidal symptoms, elevated liver enzyme, and elevated bilirubin. Of course, Wilson disease was suspected, especially that the MRI brain revealed a bilateral symmetrical globus pallidus abnormalities, and also MRI brain suggests that this is a patient of Wilson disease. So liver support were added and investigation for Wilson were done. Investigation revealed normal Kappa in 24-hour urine and serum ceruloplasmin. So the patient is not a case of Wilson. And also abdominal ultrasound revealed hepatosplenomegaly with para-aortic lymph nodes that appear in the porta hepatis. The largest was 2 centimeters. So they think about autoimmune hepatitis in this patient and that the neurological symptoms may be any other association. Autoimmune panel of autoimmune hepatitis were ordered, and the liver biopsy also was ordered. ANA was positive, but anti-smooth muscle antibodies and anti-liver kidney macrosomal antibodies were negative, and the liver biopsy revealed drug-induced liver injury. So it is not also a case of autoimmune hepatitis. So we have a patient with extrapyramidal manifestation, liver injury that is drug-induced and positive ANA. So rheumatology and immunology consultation were ordered. We see the patient in November 2020 with a delirium of new onset, rigidity, tremors. There was no past history or family history of importance in this patient. Her general examination revealed disturber, disoriented to time, place, and person with affected mood and memory. She was not cooperative, have masked face, bedridden, rigid. Her vital signs were more or less normal. Other examination was free except for upper and lower limb, which there was a rigid. Investigation revealed anemia with lymphopenia, with normal white blood cells and platelet. There is still increase in STLT, high bilirubin. Urine analysis, there was 100 milligram of protein, DNA positive, and double-strand DNA positive, and low percent of aglant were positive. MRA and MRV for the patient free, excluding any thrombotic event. So we have a patient with positive ANA anti-double strand, anemia, lymphopenia, and CNS affection. So we consider this a case of systemic lupus. And pulse steroid with 1 gram per day for 3 days were given to her with Indoxan, 500 milligram. After this, there is a marvelous improvement of the patient condition. That after the 3 days of pulse steroid and pulse cyclosphamide, the patient is conscious, well alerted to time, place, and person with average mood and memory and average intelligence. Rigidity disappeared gradually. That it was not appear at 1 week later during hair follow-up. And follow-up ultrasound reveal only mild splenomegaly. So neuropsychiatric lupus is one of the clinical criteria for SLE. Neuropsychiatric syndrome in SLE may be due to CNS infection or due to peripheral nervous system affection. It may be due to primary cause, that is vasculopathy or thrombotic event, autoantibodies like antineuronal, antiribosomal, antiphospholipid antibodies, and due to the inflammatory mediators, or maybe secondary to uremia, hypertension, steroid, or infection, or concurrent disease that is not SLE. Initially, what happened is a vascular injury and thrombosis with accelerated isosclerosis in this patient and antiphospholipid antibodies, anti-ribosomal antibodies that cause destruction of the blood-brain barrier, causing pathology in the CNS. And you will recommend for management of neuropsychiatric systemic lupus that the physician must give a necessary attention to the patient history and the physical examination in order to determine the presence and the type and extension of neurological deficit. Also, we should exclude secondary causes, the mimics condition like hypertensive encephalopathy, or the other causes that may be an aggravating factor like dyslipidemia or infection, and also a concomitant disease that may be a TTP or hypo or hyperthyroidism, or a metabolic disturbance like hypoglycemia or uremic syndrome, or it may be a drug reaction. And that CSF analyses are quite useful in determining CNS inflammation and the blood-brain barrier breakdown, which in the setting of SLE may indicate severe pathology. Also, neuroimaging is important for diagnosis like CT, MRI, MRA, and MRV. And the management, the cornerstone is the management of the disease with hydroxychloroquine, steroid, immunosuppressive. Of course, we may need antipsychotic or anticonvulsant for the CNS disease. And in some cases, we may need rituximab, plasmapheresis, and hematopoietic stem cell transplantation. An review of literature in the Archive of Rheumatology. In the TLR, it was a case report from Tang et al. About a case of Parkinsonism as a manifestation of neuropsychiatric systemic lupus of a 17-year-old girl who developed Parkinsonism within 1 month from her diagnosis with systemic lupus. And another case in the Journal of Medical Laban by Chamley in 2012, a case of Parkinson's syndrome as a complication of systemic lupus. It was a case referred of a 34-year-old female who had a systemic lupus since 11 years and developed bradykinesia and rigidity with postural tremors of her hand and diagnosed with as a case of Parkinson's. And also in the Journal of Neurological Science, there is a case report about Parkinson's syndrome as a manifestation of systemic lupus. It was a case study. So we must put in order in our mind that Parkinsonism and extrapyramidal manifestation may be a manifestation of systemic lupus. And they need treatment for the patient to be well. There are case report of systemic lupus induced by tacrolimus used in the treatment of the patient. It was published by Shimeguchi in 2010. And thank you.